today I will be with you to talk about working length determination. What will be covered today, we will talk about working length, about apical point, cemento-dentino junction, electronic apex locator, and radiographs. So let's start. First of all, we all do endodontic treatment in our clinics. Sometimes we have overfilling and underfilling. Let's talk about overfilling. Here in this case, you can see we have irritant, the very apical tissue. We have severe pain, and we have periodontal ligament breakage. In underfilling, you can see this X-ray. We can see this is a poor root canal treatment because it's not reaching to the end of the root. So we have incompletely cleaned canals, we have infection, we have microorganism. So to avoid these problems, we have to know what is working length. The definition of the working length is distance between the coronal reference point and the apical point. Let's talk about the coronal reference point. In anterior tooth, it's always the highest point in the incisal ridge. In posterior teeth, for example, in premolars or molars, we have each canal have its own reference point. So if I'm working in molar, in distal canal, for example, my reference point may be in the distal cusp or in mesial cusp. It depends on the case. Coronal reference point must be easily visualized, stable, and can't be fracture or loss. It's not possible that I will take my working length in the first visit, for example, and the temporary filling will break or something, and in the next visit I will redo working length again. So it must be stable and can't be fracture or loss. Let's talk about the rubber stub in the K file or H file. This must be feasible reference for working length, must be stable during preparation. Why? Because I need my working length, not more or less. Must be positioned perpendicular and not inclined. Why this must be perpendicular to the file and not inclined? Look to this photo. In the middle, we have perpendicular to the file. Here, my working length is 15, even if I read it from right or left, the same. But if I have inclined K file, the rubber stub, if I read my working length from here, it's 15. From there, it's 16. So I have here two working lengths, and this is, of course, wrong. The position of the rubber stub, as you see here, this is an extracted tooth. If we have this X-ray, you can see this is the same K file, the same working length, but here the rubber stub is inclined. So I have two working lengths here. As you see, that's wrong. Now let's talk about the apical point. Where is the apical end? What's my working length? And where should I stop? Apical foramen or anatomic apex or radiographic apex? Actually, there are a lot of studies and articles about this topic. We know that the cemento-dentino junction is simply the point at which two histological tissue converge inside the root canal. We know that cemento-dentino junction is partial and anatomical termination point for the preparation and duration of the root canal. So, if I can find cemento-dentino junction, it's better to end my preparation and obturation in this point. But we can't actually, because this is just histological point. We are trying always to reach to the apical construction to end our preparation and our obturation. This is some types of apical the apical construction. We can see we have type A, type B, type C, type D. This photo shows that the difference between the apical foramen and the apical construction. As we can see here, me as a dentist must be here. My obturation, my preparation, my cleaning, just here in the apical construction, not in the apical foramen or in the apex, radiographic apex. So if you see here, this case, for example, you can see this is the apex. This is the end of the root, but I didn't reach here. I reach here. It's maybe 1 millimeter short than the end of the root. But I'm always looking for anatomic apex, not radiographic apex. Here, look, this is extracted tooth. Look to the difference between anatomic apex here and the radiographic apex. Here, the dentist try to reach to the full working length by just X-ray without electronic apex locator. Look to this case, for example. Here, look to this premolar. This is the apex, the end of the root, this here. I am far away, maybe 3 millimeters or 4 millimeters, but I don't care. I'm following my apex locator. When I obturate, I can see that there is lateral apex here or here, the same. Look to this premolar. This case, I take the working length with apex locator. I make X-ray. I can see here I need maybe 1 millimeters, but actually I always trust my apex locator, not X-ray. That's why when I make obturation, I can see here, this is a lateral apex. No need to go this 1 millimeters. If you feel you are short here and you want to go down, you will make perforation. You will make false canal. Here the same, you can see. This is the anatomic apex, and this is the radiographic apex. Okay, methods of working length determination. We have radiographs, we have electronic apex locator, we have tactile sense, we have paper point test, and we have patient's pain perception. Let's talk about radiograph. The most popular working length determination method, taking radiograph with an instrument inside the canal. So, the technique is like this. We put K file, number 10 in the canal. Then we do X-ray. We will get this. Then we will make minus 1 millimeter, and this is my working length. So, the radiograph always give me the radiographic apex, and I am not going to follow radiographic apex. So I will make minus 1 to take my working length. Note that radiographs always give us the radiographic apex, not the anatomic apex. In this case, this is extracted tooth. I take X-ray. It's look that I'm fit, right? Yes, but this is under microscope. I can see that I am out. This is actually the radiographic apex. That's why I told you you have to make minus 1 in working length. Problem with radiographs. Actually, I will face problem if I have 2 canals in one root. In first upper molar, for example, in MB1 and MB2. Sometimes I will not be able to see which one is MB1 and MB2. The solution is I can make 1 radiograph for each canal. And actually, I don't like it. I don't prefer it. It's wasting my time. We can make shift technique. You can see here, for example, this case. You can see 1 canal here in the mesial and 1 canal in the distal. But when we make shift, 2 canals in distal and 3 canals in mesial. Slope technique, we all know about this technique for shifting. Same direction of the shift is the lingual canal, and the opposite is buccal canal. We can use different size or design of files. What does it mean? If I have, for example, premolar, I can't know which canal is buccal and lingual. I can put, for example, K file in the buccal and H file in the lingual. And I will take X-ray. I will know which canal K file is for buccal, H file for lingual. Electronic apex locator, we will not talk about the generation. We know first, second, blah, blah, blah. We will talk why electronic apex locator, why we must use the apex, why we must have apex locator in the clinic. First of all, the high accuracy. Actually, the accuracy is over than 90%. Reducing the radiation exposure, cumulative effect for X-ray. Solve the problem of buccolingual dimension. As we said, in this case, for example, if I want to work here just in X-ray, I need to put my K file in mesiolingual, take X-ray, take working length, put it in the mesiolingual MM canal, wasting time. Saving time, of course, and diagnoses the perforations. What does it mean? Here, for example, if I have case, especially if I have calcification, sometimes we find the canals, but we are not sure this is canal or perforation. I make X-ray, but sometimes it's in the same plane, so I can't judge I am inside the canal or outside. Here I can use apex locator, okay? If I put K-file and turn on my apex locator and if give me immediately -3 or -2, that means I am outside the root, I am inside the bone. This means it's perforation. But if I put K-file and the reading is from 3 to 1, 0.50, that's mean I am inside the canal and I can go. This is some of clinical uses of electron apex locator done by me. You can see. Okay, tactile sensation. It's about feeling the apical construction with instrument like K-file. Actually, this need experience. I don't prefer it. It's just work with the canal with patency. If the canal is blocked, we can't find the apical construction. Paper point test can be method for final checking working length after preparation. Actually, this work when I have large apex or open apex. Here, for example, after I finish my preparation. Of course, here I take my working length with electronic apex locator, but I make check with the paper point. I put this is my working length. If I can see here, for example, blood at the end of the paper point, that means I am over the apex. So this is not my working length. I am here over 1 millimeters. Patient's pain perceptions. This is when reach beyond the apex and no anesthesia. Actually, I don't prefer it. Now we will talk some clinical tips, helps you in your clinic practice. Clinical tip number 1, don't depend on electronic apex locator. Remember that electronic apex locator is important and useful with X-ray, but not a replacement. So what I do always is taking working length with electronic apex locator, and after that I make check with X-ray. Clinical tip number 2, canal should not be too dry or canal should not has a lot of fluids. What I do actually, I irrigate the canal with sodium hypochlorite, then I make air syringe, then I take my working length. Some doctors say that you have to put paper points inside the canal, make it dry, and then take your working length, but this is not correct, especially in the modern electron apex locator. It can work with fluids or blood. Clinical tip number 3, isolate well. Use always rubber dam and liquid dam. And don't forget to rebuild the tooth before you start your treatment. Actually, about me, I don't start any root canal treatment without having 4 walls of the root. So if I have just, for example, buccal and mesial, before I start, I always rebuild the tooth, 4 walls, then I will go for root canal treatment. This is better for isolation, better for taking working length with apex locator, and better for the cleaning. The sodium hypochlorite will stay in the bulb chamber, so I will get more cleaning. Clinical tip number 4, each canal has its file size. The instrument must not be too tight or too loose. What does it mean? This is mean if I'm working, for example, in upper canine, you know the canal will be wide, so it's not possible to put K-file number 8 or 6 or 10 to take working length. Why? Because this K-file will not touch or engage with all the walls. So the reading in apex locator will be like dancing from 3 to 0, 3 to 0, 3 to 0, like this. So I have to go for 15 or 20 to take in canine. The same if I use big size in narrow canal, I will not be able to reach to the apex. Clinical tip number 5, in case of open apex, I prefer to use X-ray and paper point test, because the electronic apex locator will not give me a good reading. So if I have open apex, especially in children, I don't use actually apex locator at all. It will not give you correct reading. I always go for X-ray or for paper point test. Clinical tip number 6, canal patency. Actually, there are too many articles said that the patent canals give accurate reading. So I advise you always to go beyond the apex and come back again. What does it mean? If I'm working in apex locator, okay, my reading is 3, 2, 1, 0.5, 0. Don't stop at 0.0. No, go beyond the apex, see the red lines, then come back again to 0.0. Clinical tip number 7, take the working length more than one time, especially if you have curved canals, because during instrumentation you will lose the main working length. If you have curved canal, okay, and you take working length, for example, at the beginning will be, for example, 22. After preparation and preparation, this curve will be a little of main canals. So the working length maybe will be 20 or 21. So I advise to take working length at the first and after glide bath and before obturation. Clinical tip number 8, reading on the screen does not give us a measurement or millimeters. What does it mean? You know, apex locator have, for example, here 3, 2, 1, 0. But this does not mean that millimeters or any measurement. For example, if I am taking working length and I reach for 2 millimeters, 2 here, if I reach for 2, I can't say that, okay, I need to go on, I still have 2 millimeters to reach to the apex. No, it's wrong. The same, if I reach here, for example, on number 1, I can't say, okay, I still have 1 millimeters. No, this does not mean millimeters. This is mean that if I am from 3, 2, 1, 0.5, 0, this means that I'm coming to the apex, but no millimeters. The same, if I am from 0 to 1 to 2 to 3, that means I'm going far away from the apex. So if you stop here, don't think that you are far away 2 millimeters from the apex. Maybe it's 4, maybe it's 10. No one knows. This is just a reading for just to know that you are coming to the apex or far away. At the end, the electronic apex locator actually is a magic tool, but without a good magician, dentist, it will not work well. We reach to the end. Thank you for attention. Any questions? Yes. Yes. For the calcification, okay. First of all, we have to know that the calcification always starts from the coronal to the apical. So, if I have calcification case, okay, I opened, I reach to the bulb chamber, for example, I can find the canal, okay, but I can't go inside the canal. Okay, can I stop here or no? This is what you mean? Yes. Actually, yeah. Actually, I will always try to reach to the apex, but sometimes actually we can't. Severe calcification. In case if we have periapical lesion, this means that already 100% I have a canal. No calcification here. Even if I can't see the canal, even in X-ray it's blocked. Here I can use CBCT, but there is a canal. And here I have to reach to the apex. I can't. I have to. If I didn't, maybe I will go to surgery. But I can't leave the tooth, especially if I have periapical lesion. But if I don't have periapical lesion, I remove the pulp chamber, I reach, for example, middle of the canal, Sometimes I can leave it. I can put MTA and go on. The rest of the bulb, calcification. It's vital. It's vital. And when MTA touch this vital, it's okay, no problem. So if I have periapical lesion, I need to solve the problem. I need to reach to the apex. Even go for surgery. Go for surgery. You can't leave this periapical lesion. Why? Because this apical. Okay. Yes. Is it vital or not? Not vital? If it's remaining roots, we need to extract. To extract. No apical region, no periapical lesion, no pain, no symptoms, leave it. Yeah. If we have no problems, no symptoms, we can leave it. Sometimes actually we remove just the bulb chamber, the bulb in the just in the bulb chamber, and we see, for example, some cases. Actually, I faced some cases. Patient came, for example, with periapical lesion in medial canals, in molar, for example. I open to make root canal treatment. Okay, I go for distal canals, for example. The bulb is vital. Believe me, the bulb is vital. The patient feel pain, but in the mesial, necrotic, no bulb. In this case, actually, I can do root canal treatment for the mesial canal and leave the distal canal. You can just put MTA and leave it. No problem for that. You're welcome. Actually, this is recently studies that we can go instead of gota bersha with MTA. This is possible, actually. There is a professor from Japan. You know him, I think. He's famous, Yushi Tirushi. He's from Japan. He makes studies. He make root canal from maybe 10 years or 12 years or more. He didn't use gota bersha or sealer inside the canal. So he make root canal treatment, cleaning, shaping, and then he obturate all the canal with MTA, all the canals. Of course, here in preparation, difference than preparation with gota bersha. But nowadays, actually, we can do this. It's possible to put all the canals with MTA. But actually, I can say there's some problems in this procedure. Redo the endo, re-endo. If you want to make retreatment, you will face very difficult case. Why? Because you know MTA, what does it mean? Very stuff. You can't remove the MTA easily. So actually, in my opinion, I can say let's do both. Let's use, for example, bioceramic sealer with gota bersha. So I will use here the MTA and I will put inside it gota bersha. In case in the future I want to make retreatment, I can remove the gota bersha. Then if I remove the gota bersha, the MTA will be on the wall. I can break it with ultrasonic tips. But if I have all block of MTA, very difficult to make retreatment. I didn't get when I use apex locator. Okay, actually this is different protocol. About me, when I start root canal treatment, I always open the access cavity. Okay, then actually I'm a fan of crown down technique. Okay, protocols. So I always prefer to use SX, you know, to just open 2 or 3 millimeters, 2 or 3 millimeters from the canal. Then I will go immediately with apex locator. I will use K file number 10 and go for apex locator. I will reach. Hmm? Yeah. Not? Not vital cases. With the bus, actually, the same protocol. I always use crown down. So here I will prepare. Actually, I will try to prepare as much as I can from the coronal part, trying to avoid pushing this bacteria to the apex. So I will go with the 2, 3, 4 millimeters. Then I will go with the K file with the electronic excavator. So actually, about me, the same protocol. I always try to use crown down technique. It's always like this. You're welcome. Any questions?